Good afternoon or good evening, everyone. I'm Dr. Adamson, and today we are going to have a very interesting time. We are taking the topic, the Furlow technique for cleft palate repair. And taking that will be Dr. Sami Orok Oben, who is a plastic surgeon, plastic anesthetic and reconstructive surgeon working at Adassa Medical Center, Simbok, Yaoundé in Cameroon. And he has served since 2013 as Smartring Partner Surgeon, working under the banner of the We Care Foundation. So he's the one to take us through it. So I encourage us to have our questions. There's the Q&A session there. You can type down your questions while the lecture is going on. And after the lecture, we have an interactive session. So Dr. Oben, you have the floor.
Oh, good afternoon, good evening, good morning, everyone, no matter where you're listening to us from. Welcome to today's Smile Train Telecleft. My name is Dr. Oben Sami Orok, as you've heard, and today I'll be talking on the topic cleft management and for the follows technique. So as I said, I'll be talking on palate cleft surgical management and the follows technique. That's my disclosure. We would use the following plan. We'll have an introduction. We have a clinical presentation, diagnosis, classification, management. Then we get to the follows technique and then potential post-op complications and conclusion. The reason why I use this plan is so that we can position the follows technique in the armamentarium of cleft palate management. Definition: the cleft palate is just a congenital opening at the roof of the mouth resulting from incomplete fusion of palatine processes during intrauterine life. It is of various severity affecting either the hard palate, the soft palate, or both. It can also be complete or incomplete, syndromic, or non-incidence of orofacial congenital anomalies. And psychological implication on both. Medics have already been employed or are currently being employed, resulting with various different, some satisfactory, some unsatisfactory, and there is a lot of unsatisfactory outcomes as far as speech and scarring of the cleft is concerned with these techniques. But the double opposing Z-plasty by Dr. Leonard Furlow greatly revolutionized the way speech, the functional speech outcome, and greatly improved the velopharyngeal competence. Let's look at epidemiology. The incidence of cleft is 1 in 1,000 live births in sub-Saharan Africa. But the clefting in my own country, the incidence is quite on, which leave us a place for something to be done. The etiology, the exact cause is unknown, but thought to be multifactorial, involving genetic and environmental factors. Some risk factors have been identified, which include family history, maternal smoking, and certain medications that are taken during pregnancy. Cleft palate is more syndromic than cleft lip. Let's do some recalls. Let's recall about the embryology. First, the cleft palate develops from the fusion of several embryonic structures. The anterior part of the cleft palate, which is known as the premaxillary. It comes up from the 6 to the 12 weeks of gestational age, and it mostly involves the inward growth of the palatine shelves. As I said, factors influencing this fusion will include genetic, environmental, and nutritional. That's what happens in the intrauterine life. Let's recall the anatomy. The structure. The palate is the structure that forms the roof of the mouth and separates the oral from the nasal cavities, which are two very important cavities that are responsible for eating and for breathing. Anteriorly, we have the hard palate, which is primarily the bone made up of the maxilla and the palatine bones covered with a thick oral mucosa. Posteriorly is a soft palate. A soft palate is a valve-like flat sheet structure, which we call the velum, consisting mostly of muscles and connective membrane. You can see from the picture, there you have the hard palate and the soft palate behind. Let's look at some vascularization, which is very important for every cleft palate surgeon to know. Cleft palate has a rich network of arteries and veins essential for eating, which also note some of these are end arteries. They become end arteries after certain surgical dissection, thus potential for vascular complications. Let's recall the hard palate arterial supply. It is mostly the greater palatine artery, which is a branch of the maxillary artery, which passes through via the greater palatine foramen to supply the anterior palate. The anterior, we also have the anterior superior alveolar artery that supplies the anterior portion of the hard palate. Let's look at the vascularization of the soft palate. This is mostly from the lesser palatine artery. Again, it's a branch from the maxillary arteries and supplies the soft palate and the uvula. We also have the ascending palatine artery, a branch of the facial artery that supplies part of the soft palate. The venous drainage follows the arterial supply is mostly the pterygoid plexus, and we also have the fascial vein. Now you can see from the anatomy, you can see how these arteries are being displaced. And you can see on the right-hand side, you will see a detailed diagram that shows the greater palatine artery and the lesser palatine artery. The greater palatine artery supplying mostly the hard palate, while the lesser palatine artery is responsible for the soft palate. What about the nervous supply? This is critical for sensation and function of the palate. The primary branches are from the maxillary division of the trigeminal nerve, which is the second cranial nerve. The hard palate, you have the maxillary branch, as I already said, from the greater palatine, it passes through the greater palatine foramen, supplies the sensory supply to most of the hard palates. The nasopalatine nerve, also a branch of the maxillary artery, via the incisive foramen, it supplies sensory supply to the anterior palate. There you can have that. Let's recall the physiology, because that's where the whole problem is, the hard palate. The hard palate contributes to chewing and manipulating food in the mouth. The soft palate is responsible for separation of the oral and the nasal cavity, facilitating speech, aiding in swallowing and breathing. You can see that is the velopharyngeal dysfunction. Well, just showing that you have the hard palate and the soft palate, and the soft palate has to go behind to block the posterior pharynx so that you can be able to produce certain sounds, which are called nasal sounds. Now, I also introduced this slide, which is called the surgical anatomy. If you look at this slide, it's a surgical, the first slide is surgical, and it shows a trans with some very important muscles. One, you see the velum behind and the hard palate in front. On the velum, you now have the levator-velar palatini muscles. You see how it elevates the velum. We said the velum is a valve-like sheet, it's a valve. This valve has to be elevated to block behind. That elevation is done by the levator-velar palatini muscles. Then you also have the tensor velar palatini muscles on the right-hand side. You see the tensor velar palatini muscles. These two muscles are very, very important for speech. While the levator velar palatini muscle will elevate the velum to close the posterior, to impact on the posterior pharynx, the tensor velar will open the velum like a sheet so that the closure is very, very well, is properly done. And this tensor velar palatini muscles goes up and goes through the hook of the humulus. You see, the pterygoid hamulus. You can see that hook there. That hook, that's where the tensor velar palatini muscles goes there. Now, next slide. Now, I also introduced the surgical anatomy. If you look at the surgical anatomy, you look on the right-hand side, you see the actual anatomy. You have the hamulus, you have the tensor velar palatini muscles that goes through the hamulus to stretch out the velum like a sheet. And then you have the levator velar palatini muscles that elevates the velum. And then you also have the uvular muscles, or the uvula, which is a small muscle that is behind. But in clefting, these muscles do not cross to the other side. So there is a complete opening whereby the muscles act independently, and thus they are unable to do the proper function of elevating and impacting the velum. You see this surgical anatomy on the right-hand side. Now, the clinical presentation, very simple. The child is born with an observable gap or a hole at the roof of the mouth that affects breathing, eating, speech in older children. This child will face challenges in feeding, in breathing, repeated upper respiratory tract infections, including ear infections, dental, cosmetic problems, and poor purely clinical, except for intrauterine diagnosis that is done. Except for intrauterine diagnosis. Are you getting me? Because I'm having them, they're telling me that my internet is unstable. Hello, Dr. Adamson,
Yes,
are you getting me?
Yes, we are.
Okay, thank you very much.
We can
the diagnosis is purely clinical, except for intrauterine diagnosis that you can see the clefting of the lip, and you can extrapolate and say, well, this clefting may have a clefting of the palate. The classification, several classification schemes for cleft palate exist, but for this discussion, we will limit ourselves to very simple things like syndromic and non-syndromic and syndromic, hard or soft palate, complete or incomplete. The management of cleft palate is multidisciplinary in approach and comprehensive in its rollout. The team will include the midwife, the neonatologist, the cleft surgeons, the genetic counselor, the nutritionist, the oral and maxillofacial specialist, the audiologist, the speech and language pathologist, the psychologist, the social worker, pre-surgical, and so on. So the cleft palate surgical correction is what we're interested in. Cleft palate can have a deleterious effect on both the health and childhood development, including malnutrition, speech anomalies, psychological consequences, and social isolation. Therefore, surgical correction is the gold standard treatment when attempting to restore palate form and function. Cleft palate surgical correction, the importance and is crucial. This is crucial for several reasons. You have functional, you have preventive, functional improvement, speech, feeding, you have preventing complications such as ear infection, dental issues. And I try to bring out from this paper, I brought out this diagram to show the cleft palate armamentarium. I just want to show where Furlow's technique is found in this cleft armamentarium from the very beginning. Cleft palate, hard and soft palate were considered two different entities, and their surgeries went different. I just want to bring out what every person was able to do. As I said, initially, soft palate and hard palate repairs were considered as separate entities. As such, the techniques were developed very, very isolatedly. Hard palate surgery was developed much later than the soft palate. First, we have the French dentist Lemonnier. He did something very important. He cauterized the soft palate cleft edges and sutured them together. And he found out that there was great improvement in the speech of the patients. Then Von Graff did something very important. He de-epithelialized the edges of the wound, then closed them anatomically. He is the first person that described the soft palate as the most important voice-forming and voice-influencing structure and urged surgeons to repair it. Then we look at Diefenbach. Diefenbach is the first person that did periosteal elevation. Von Langenberg did the first bipedical flap elevation. Vaux Victor Vogt did some very important things. First, he brought the unipedicular muscular flap and introduced the three-layer closure of cleft palate, which is a very important thing. The mucosa, the nasal mucosa, the soft palate musculature, and the oral mucosa. He described the abnormal arrangement of soft palate musculature in the cleft palate patient, just as I showed in the previous diagram. Vogt also advocated separating the soft palate musculature from its insertion on the posterior hard palate to lengthen the soft palate, some kind of a foot pushback, and this to reduce tension on the mucosal closure. However, he did very little in the orientation of the muscles. Then, Voidil-Kilner brought the lengthening with the VY pushback. Baghdad brought the two bipedical flap, which helped to close the anterior margins of and prevent exposure of the bony maxilla. Then, Otto Krian is the one that described the intravelar veloplasty. He corrected what Vogt has started. He tried to make sure that with a microscope, they were able you are able to dissect the muscles and actually repair the muscles one to the other. And this has been greatly worked upon by Brian Summerland. Well, these are all milestone techniques for functional soft palate repair, restoring function and of the muscular and function of the muscular sling to reduce medial ear infection and improve motion of the palate and speech. Now, so we can see that most of these early techniques were mainly to cut open, bring the tissues together anatomically, neglecting the principle of palatal functions, which was the repair of the muscles. This resulted in shortening of the palate through scarring, contracture, immobile palate, ultimately causing speech defect. Subsequent techniques prioritize principles that will lengthen the soft palate. However, complications and poor speech was there. Otto Klein was a milestone. Now, there was need, therefore, for a simple, innovative, functional technique to resolve, if not all, of this issue. Furlow in 1978 reported a revolutionary soft palate cleft repair technique, which with so many benefits in a single procedure. It involves the creation and transposition of two Z-plasty flaps anteriorly and posteriorly. These are the advantages of the Furlow technique. It allows closure of the hard palate in one procedure while lengthening the soft palate without the need for pushback, realigning the musculature and reconstruction of the velopharyngeal sling, reducing palatal scarring and increasing palatal mobility, and decreasing negative effect of maxillary growth. Therefore, we see that early cleft palate repair with restoration of articulation and adequate speech development are crucial in childhood development, speech, and social integration. However, prioritizing speech through early cleft palate repair can lead to maxillary growth restriction with mid-phase growth delay, often warranting later surgical correction. Conversely, prioritizing mid-phase growth by delaying hard palate repair could potentially result in speech errors that may or may not be corrected by further surgery or speech. The relative importance of difficult to correct speech over easy to correct facial growth disturbance are constantly debated among proponents of the various approaches. Smile Train prioritizes speech while taking into consideration maxillary facial growth disturbance, favoring early cleft palate surgical repair as from 6 months of age. Cleft palate surgical correction. What is the global consensus? A standardized techniques and good timing that will achieve anatomical closure of palate defect, optimal velopharyngeal competence, minimizing the occurrence of maxillary hypoplasia, minimizing post-surgical palatal complications. These are some of the advantages that Furlow technique brought for us. Now I try to look at some of the management, the benefits that come with surgical corrections. These benefits are not very nice. Now let's get to the Furlow technique. As we said, it's a surgical procedure described in 1978 by Dr. Leonard Terry Furlow. It involves the creation of and transposition of two mirror Z-plasty, an anterior mucosal flap and a posterior myomucosal flap. The technique aims to achieve optimal anatomical and functional outcome by using double opposing Z-plasty approach to reposition the levator velar palatini muscles responsible for greater improvement in speech outcome. I've already talked about its advantages. That is the biography of Furlow. And there is a Furlow. I just want to let you know that Furlow died 1 year ago. His wife had died before him. What are the indications for Furlow technique? Isolated cleft palate, particularly effective for complete and incomplete clefts of the soft palate, primary palate repair. Cleft lip and palate. When cleft lip and palate are present, especially when the palate is significantly affected, but narrow. Soft mucosa cleft palate, where palate is partially or completely open, but covered by a thin layer of tissue. Muscle layers are not properly aligned, leading to speech issues. Secondary cleft palate with VPI. Now, a patient may have indications correct for Furlow technique, but there are some criteria. There are some criteria that you need to follow. What are these criteria to determine which patient is suitable for Furlow technique, even if the indication is correct? Number one, age. Typically is between 8 to 18 years old when the child is developmentally suitable for surgery. The health status, the child has to be in good health without significant comorbidities that could complicate surgery or recovery. Severity of cleft. This is where I've had some problems. Ideal for well-oriented narrow cleft palate that allows for effective muscle repositioning and flap correction. Be careful, don't take wide palates. Speech assessment. Patients exhibiting speech delays or disorders relating to cleft palates are good candidates for these techniques. Parental support. You need cleft palate follow. You need commitment from caregivers to follow up with post-operative care and speech therapy. What are the materials we need? We need general anesthesia. We need cleft palate surgical set, including a good mouth gag. We need a resorbable multifilament sutures. We need surgical consumables, xylocaine, and adrenaline solution. This is the Dingman, the mouth gag, and I really want to thank SmileTrain for giving this. This is one of the best mouth gags I've ever used. What are the pre-operative workup have to be done? Pre-anesthesia consultation. The patient is under general anesthesia with orotracheal intubation, very important. The skin and mouth preparation is done as required. An open mouth guard retractor of choice is placed. We use the Dingman mouth guard, which is provided by SmileTrain. Let's look at the step-by-step preparation. I'm talking about a right-handed surgeon standing at the head of the ORO table, looking down at the patient's head into the oral cavity. For open cleft palate, start by closing the uvula. You close the uvula in 3 layers, just as Victor Vo told us. You can also use tack stitches to approximate the free edges of the cleft palate. This will give the required tension needed for dissection of the flaps. The design of the flap is determined by the underlying palatal anatomy. First, the superficial Z-plasty. The central segment corresponds to the palatal cleft, starting just above the closed uvula to the posterior border of the hard palate, falling short of the levator aponeurosis. The anterior horizontal limb, the first anterior horizontal limb, is about 8 to 10 millimeters, runs along the posterior border of the hard palate towards the hamulus, but stops short from reaching it, the left side of the surgeon and patient. That's what I'm talking about. The posterior horizontal limb is on the right-hand side of the surgeon. It runs just above the close border, the closure of the uvula, and runs to the region of the contralateral hamulus, making an angle of approximately 60 to 80 degrees, depending on the length of the velum. The first or superficial Z-flap marking incision is done, and then the incision and flap elevation is now proceeded. Posteriorly based flap. So the first flap is a flap on the left-hand side. It's a posteriorly based flap, which means the vascularization is from behind. The vascularization is coming from behind, from which artery? From the lesser palatine artery. It's elevated as a composite myomucosa flap containing the muscles and the oral mucosa, containing the tensor velar palatini muscles, and its attached oral mucosa covering. And its attached oral mucosa covering, thus elevating it from the nasal mucosa. So you're going to elevate this composite posterior flap because the vascularization is based posteriorly, you elevate it technically, very carefully from the oral mucosa. Be careful not to perforate the oral mucosa. While the contralateral flap is raised to contain only the oral mucosa. This is the anterior flap. Next. Now, the second or deeper Z-plasty, the central segment stays the same as the first, but its limb runs in opposite direction to the superficial Z-plasty. That is, the side that had the limb incision at the base of the posterior border of the hard palate now have its limb incision parallel to the posterior border of the soft palate. The incisions and flap elevations, we have the posteriorly based flap contains attached nasal mucosa and the tensor velar palatini muscle. Again, the vascularization if this is from the lesser palatine artery, while the anteriorly based flap contains only the nasal mucosa. Now, you can see from this diagram, this is the anterior flaps. You see the superficial flaps. You have the superficial Z-plasty, oral mucosa, and muscle. On this other side, the superficial flap is the oral mucosa. Now, the deeper flap, you now see, again, the anterior flap is the deeper Z-plasty nasal mucosa and the posterior flap. So the posterior flaps are always mucosa and muscle, and their vascularization particularly is from the lesser palatine artery. Well, you can see that is what it looks like. And post-op, that's how it looks like. This is the diagram. You can see what I was describing to you. You see the limbs, and that is the uvula there. And that is the first repair is the repair of the uvula. And you have now, you can put tension stitches, and then you can go ahead and start doing your cutting your Zs. Transposition and closure. Now, in transposition, first, we transpose the deeper Z-plasty. You remember the deeper Z-plasty contains the muscles and the mucosa, and we close them without tension. Second, we close the superficial Z-plasty. Transpose. The superficial Z-plasty, which is the anterior part, contains mostly mucosa. You have the oral mucosa and the nasal mucosa put together. This step to step, that's you have the transposition and closure. Now, let us look about the overall effect. We have orientating the levator velar palatini sling into a more normal anatomical position. You see, Furlow's technique is so good. It's different from autocrine's technique, because in autocrine's technique, you need a lot of, you need like what Brian Summerland is doing. You need microscope, you need surgeon's experience. Furlow's technique uses simple things. You don't need to think too much. You just need to know where your muscles are, and the muscles will be pushed behind. So you just have the muscles pushed behind and the mucosa in front. And if the muscles are pushed behind, then you are probably most likely bringing the sling of that muscle into its anatomical position. It increases the length of the soft palate. That's one very important thing that the Furlow technique does. Of course, we already know as plastic surgeons, some of us, Z-plasty leads to lengthening. So you have to, Furlow's technique will lengthen the soft palate and give you that impaction that you need on the posterior pharynx. Some surgical tips. The levator muscle must be completely released from the posterior edges of the hard palate and from the tensor aponeurosis to allow complete repositioning of the reconstructed levator sling. The use of lateral relaxing incisions may be there. You may use them or may not use them. Sometimes I don't use them. Will allow tension-free closure and minimize the risk of oronasal fistula. That's something you should prevent. Attention, avoid perforation on the fragile oral or nasal mucosa. This will bring you a lot of trouble. Be very careful with the vascularization, because if you tamper with the vascularization, you may end up with a lot of problems on your hands. What is the post-operative care? The patient goes to PACU for close watch and monitoring. Pain management is something that is very important. We administer painkillers to relieve and to manage discomfort after surgery. Dietary restriction. I do dietary restriction mostly to soft, semi-solid fluids, liquid diet, recommended initially to avoid irritation to the surgical site for 4 to 8 weeks. Oral hygiene is very important. Maintaining good and oral hygiene is essential. Follow-up appointment is a regular follow-up with surgical team and speech therapists. Is very important to monitor healing and assess speech development. Activity restriction. It is very important to restrict children, especially suckling. What we do in our setting is that we glove the hands of the patient, of the children, and try to avoid them putting their hands into their mouth. What are the potential post-op complications? Speech issues. Yes, you could still have some speech issues, if especially if the surgeon is still on the learning curve. Well, this will improve with time. The velopharyngeal insufficiency. This could also happen again, as I said, if the surgeon is still climbing the surgical ladder. But you could have other things like bleeding, like perforations, and these ones are the much more serious ones. Well, I want to thank you very much. I will end here. These are some of my references that I used to prepare this. I hope I've been able to do the much that we can do for today. So we'll just wait for some questions. Thank you.
Thank you very much, Dr. Oben. It was a well delivered lecture. And I know definitely that our audience too have learned one or two things from it. We have a couple of questions. I also have some, but I think I'll take the other questions first before mine. So from Priska Palata asks that after 6 months of age, can we correct speech issues of a child? Did you hear me, sir?
Yes, I got you. I'm just noting them down. I will just
okay,
note
should
them
I ask all the questions first? Okay.
Yes.
The second one is from Professor from Dr. Akintububo. He asked, he said, thanks for the beautiful lecture and demonstration. But the question is actually for Smart Train, that can we have live surgery for training of surgeons? Because it's easy to discuss, but better when it's seen live. And also Abdullah Mahmoud Adan asked that, can the embryology be repeated? The embryology. And Shemiu Adeni asked that, does nasogastric tube, is it useful in feeding of the patient? That's NG tube. Is it useful for feeding of the patient? So I want to add mine too. I have about one or two. First thing that if we are doing a hard and soft palate, can we use Furlows for it? And if you are doing it, how is it done? And secondly, if we have a wide cleft, what are the options? Because you mentioned that Furlows is not suitable for wide clefts. I just like to know which options are available for wide cleft. So I think we can take these questions right now.
Okay, thank you very much for the questions, and thank you so much. Thank you, Prisla, for your question. You asked, what can be done about speech after 6 months? Well, we know that vocalization starts at 6 months, and that's the reason why the Smile Train protocol demands that we can repair the cleft palate before the child really starts vocalizing from 6 to 7 to 8 to 9 months. Instead of some people who say you repair at 9 months, when the child has already learned to vocalize, and when you repair at 9 months, the child has already learned a wrong way of talking, and it's not very good. In my practice, I have seen patients that I operated at 6 months. They vocalize so well that sometimes I'm really amazed. I'm amazed at the way they vocalize. And so it's very important. Yes, you can correct speech after 6 months. It can still be corrected. It just depends on what you want to correct. My friend, Dr. Akim, he says, yes, I agree with you, your question on training. I think it's very important. Follow technique is a is a technique I find very important, more important than Brian Summerland's technique, than Otto Krine's technique, which are really cumbersome, and you need a lot of experience. You need a lot of, I say those techniques are only when the patient can pay you very well, and you have a microscope to go and start looking for those things. Follow doesn't need all that. You just need you can just do it simply. So I think Smart Train should encourage the fact that, especially as Smart Trainers, puts follow technique as the technique to be used for secondary palates. It's good that surgeons should be trained to adequately do it, and Smart Train can do that very well, especially with wax involved in it. Now the embryology, you want me to repeat the embryology? I think Smart Train will make this available to you so that you can be able to go through the embryology of the primary palate and the soft palate, which are all on this slide. Smart Train is going to make these slides available. That's why some of this slide is so many, so that you can be able to look into it. Then Dr. Adam, somebody asked about the NG tube. I have never used NG tube. I've never used NG tube for my cleft palate patients or a follow technique. I've never had a reason for using NG tube, but I don't know. Maybe some surgeons they do use NG tube, but I don't find the importance of NG tube, because our babies can eat on their own, and we encourage them to eat on their own. I think that an NG tube may even create some kind of irritations that can cause more problems. So it's good to avoid that. Now, Dr. Adamson asked about the follow. Dr. Adamson, can I get your questions again, please?
Okay, just a minute. The first question is, can the follows be used when you have hard and soft palates? And if it can, just give us a brief of how it can be done, maybe compare with other flaps or other techniques.
Yes.
And also, secondly, sir.
Let me take the first question. Let me take the first question, Dr. Adamson. Now, if you look at this slide here, this shows that follow can be combined. In fact, when you combine follow, you have this kind of Z plastic on your thing. And at one time I was in Gabon, and we're doing follow technique, and once you combine it, you have this kind of presentation. It is very possible. I do combine it. It's true that very rarely do I use follow technique for primary palate closure. I use it mostly for secondary palate closure when the palate has been closed, but you can use it for a primary palate closure, both the hard palate and the soft palate. Then the second question, the white palate. Dr. Adamson, I tell you the truth. I tell you the truth, sir. Avoid using follow for white palate. You will sweat very badly, and you may end up doing a buccal flap, a buccal mucosa flap, to go and close the defect that will be left, because follow will not give you. The 2 times I've done follow with wide opening, I had to go and take a buccal flap to come and close the deficiency. So I will advise you that please follow those criteria for those ones that I've given you. Use especially as a young surgeon, let it be very low. If you have a wide palate, use another technique. Stay away from follow.
Okay, I think we have more questions here.
I think you had a third question.
No, just 2. You've answered both of them excellently.
Okay, yeah.
There are more questions here.
Okay.
Priska also asked that what causes children to be born with speech problem? Maybe just have to say that again. And also Godwin Kitongo asked that, is follow palatoplasty a 2-stage procedure? And another anonymous attendee asked that, is it not safer to repair the cleft at 9 to 12 months, since babies are obligate nasal breathers up to 6 months? And also, what is the comparative speech outcomes between those repaired in 6 months and those at 12 months?
Okay, let me start from the last question.
Okay, sir.
I think I support the smart train protocol to repair the children at 6 months. All you just need to do is for the surgeon to be, it's very challenging. You just need a surgeon to be experienced, and you can have a nice repair at 6 months. When you see that baby at 9 months, 1 year, you listen to the speech of that baby. It is completely different from the babies that I see at 9 months and repair their palates. Again, as the speech pathologists tell us, it's because the baby has learned to speak with a nasal wah, 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 like that. So it's very difficult for the baby to unlearn, of which if you repair the palate at 6 months and the baby is able to learn to speak properly before that time, you have a better speech. I believe, and you can read the papers, it is better at 6 months than at 9 months. Now, the second part of your question, you asked about whether it is safer for 9 months. Again, as I told you, it all depends on your anesthetic platform. Is your anesthetist, are they able to put your babies to sleep at 8 months, at 6 months comfortably? If they can put the baby to sleep at 6 months for you to do the leap, at 3 months for you to do the leap, I think at 6 months they will be. Do your proper pre-op, pre-surgical workup, follow your nutritional protocol, make sure your child is well nourished. Don't take a malnourished child. You'll be looking for trouble. Make sure the child has enough blood, the hemoglobin value is good, there's no concomitant infection. You can comfortably operate at 6 months. I've been operating at 6 months. It's very possible. Now, the second question. Some Priska asked about what causes speech problem. Well, Priska, this comes from this slide, here. I tried to show you a physiological slide here. Yeah, let me go back to that slide. That's the reason why we have this slide. You see, this is a normal patient. In a normal patient, for you to talk, for you to swallow, your soft palate needs to go behind and close the nasal passage so that you can swallow. Food doesn't enter the nasal passages. For you to pronounce certain words, you need to have your soft palate go behind, block behind, for you to be able to produce certain sounds. But in clefting, that function is lost. And it cannot be done because the muscles don't come together and there is an opening. So this child has difficulties with eating. When the child eats, food will enter into the upper respiratory tract. When the child wants to talk, the child is unable to pronounce certain vowels, which are nasal vowels. So I think I've answered that question. What is a follow-up in? Yes, there's a question about 2-stage. Well, as I told you, cleft palate, hard palate and soft palate, initially surgeons were doing it at 2 stages. But you follow technique can be done in 1 stage. You don't need to do it in 2 stages. You can do it in 1 stage. You can also do it in 2 stages. If you don't have the experience, you can close the soft palate and then later on come and close the hard palate. But I tell you, it is much more, it's better to do it a 1-stage procedure.
Okay. Someone has also asked that what precaution should we take during Furlow surgery?
The caution to take during Furlow surgery, do not, I think I brought something here for you. I said, be very careful. There are certain things. Number 1, take care of the vascularization. Please be very careful. Be very, very careful with the vascularization. Don't play with it. It can mess you up. If you destroy one of those vessels, you will be in serious problems. You'll be in real serious problems. So take care of your vascularization.
Okay, thank you. There's still more questions.
That's not all. The second thing is the perforation of the nasal mucosa. It's very easy to perforate the nasal mucosa. If you perforate it, it is very difficult to repair it. So you have to be very careful.
Okay, thank you very much. There are still more questions coming in.
Okay.
So I'd like to ask again that you stuck on the oral care, including feeding, following the Furlow's technique.
Yes, the oral care feeding, as I said, we start feeding our babies the next day. We just make sure that when they are fully out of anesthesia, once babies are fully out of the anesthesia, they are able to have the swallowing reflex. It's very fine. We feed them semi-solid food. I don't even start with semi-solid. I start with just liquids. Just give them liquids. Give them liquids for about 48 hours to 72 hours. After that, you go to semi-solid foods. Make sure you tie their hands. So they don't put their hands into their mouth. Because the problem is that when you have a problem with the Furlow technique, the salvage surgery is a single Z plastic, which is also very difficult to do. So try to make sure that your Furlow doesn't have a problem. Don't allow the children to eat biscuits, to put sweets on their mouth, to eat fish or meat or something that is fried. It must all be semi-solid. Washing the mouth is a difficult one. Just give them mouth rinse with water. Just give them mouth rinse. Just give them water. They'll clean their mouth because you won't go brushing their mouth. You'll probably go and cause more trouble than anything. Just give them water to rinse after every time you feed. Give water to rinse to take away debris from the mouth.
Okay. So there are still more questions coming in and comments. I think Dr. Obadi said that he feels that the Furlow's technique is very important for cleft palate speech to prevent VPI. And he said, in his opinion, it needed to be taught carefully that the surgeon must have a basic principle of clap before practicing, especially the proper indication, patient selection, and technique. So he feels that surgeon must have training in basic principle of flap surgery before follows. But you have said that it's straightforward. What do you have to say about that, sir?
Well, as I said, it's a very good technique, and Dr. Akintokumbo already said it is important to train. You can't do a Furlow technique if you have not been trained. You can't try it because you cause so many. You need assistance when you do your first technique, your first surgery. You need someone to go with you. Furlow's technique has training. You must be trained. But it is not as difficult as Otto-Krine's technique or Brian Summerland's intravelar veloplasty using the microscope. That's what makes the Furlow's technique very simple. It doesn't need so much to do it. You just need simple instruments and you go ahead and you have a beautiful surgery. So training is very important. And I still again encourage my train that in one of our sessions that will come up, Furlow's technique should be brought up so that surgeons should be trained en masse to be able to do Furlow's technique as a secondary cleft palate closure and in VPI speech treatment is very important. Hello?
Okay. Still more questions.
Yes,
hello,
I can hear you. Very 5 on 5.
Can you hear me?
Yes, 5 on 5, Dr. Adamson.
Okay, yes, yes, okay. Yeah, Sylvain Kuratue asked that, can you share with us your experience in management of palatine arteries injury during cleft palate surgery? Like, what's your experience like when there's an injury to the palatine artery?
That's a very serious question. I have had one palatine, anterior, the greater palatine artery injury. Unfortunately, you know, in the anatomy of the greater palatine artery, there are sometimes you have more than one artery involved there. You can have 2 arteries. I've seen a patient with 3 arteries coming out from there. In this patient, I had a mid-palatine artery injury. I don't know what happened, but the flap died. The anterior part of my flap, I was doing a backdash technique or two-flap palatoplasty, and the anterior part of the flap died, leaving a big hole. I had to bring the patient back to the hospital and did a tongue flap. I took the anterior tongue flap, brought it there, put it on that hole, and the patient stayed with me using NG tube, a tube feeding for 4 weeks. After 4 weeks, I did severage of the flap, closed the tongue area, and it was a beautiful, beautiful correct repair. And this patient is doing well up until this day. Be very careful if you don't know the salvage techniques or how to handle complications. Be very careful when you do palate surgery, not to injure the greater palatine artery. If you injure the posterior palatine artery, your problems are even worse than the anterior one. But of course, you have this ascending branch of the facial artery. It can help you. It can help you there, but you have to be very careful.
Thank you. There's still Priska still asked that after the surgery, how long does it take for the patient to recover?
My patient recovers immediately after anesthesia. The patient is up and doing. You know, children respond very fast. Within a couple of days, the child is the first 2 days the child will be crying of pain. By the third day, the child doesn't cry anymore. And by the fourth day, or when the child is going home, I send the children home by the fifth day. You see them running. You see them running around. So within 1 week, the child is doing fine. The child is kicking well.
Okay.
But again, remember the rule of feeding. 2 months, they should have semi-solid food because you don't want anything to happen to that repair.
Thank you very much, Dr. Ben. I think we've exhausted all the questions asked, and I want to appreciate you for the the seminar, well delivered, and I'm sure our attendees and everyone has learned 1 or 2 things from it. So I think we've come to the end of today's seminar. Dr. Ben, I'm sure with SmartTrip we can work on something on maybe live surgeries or trainings for surgeons that are interested. You know, like was mentioned, these things are, well, you can see them, but it's best when you actually participate or see the live surgeries. It makes things easy and it sticks better. So once again, we've come to the end of today's seminar. Thank you.